So dear chair, dear audience, let me present you my progress on my PhD thesis, which is the impact of uterine surgeries on clinical and reproductive health. My name is Lőrincz. I'm a medical doctor and a full-time PhD student at the Department of Obstetrics and Gynecology at Semmelweis University. And my vision are women without postoperative complications after uterine surgery. And my mission is to find uterine surgeries, surgical techniques with the least amount of complications. Right now, I have two ongoing projects. Both of them are systematic reviews and meta-analysis. The first one is investigating the efficacy and safety of different caesarean section layering techniques. Caesarean section rate continues to rise globally, right now accounting for more than 1 in 5 of all childbirths. We can see that this rate in Europe is even higher, and it is estimated that by 2030, nearly a third of all births will take place via caesarean section. Caesarean scar defect is an underestimated pathology due to clinicians' unawareness, and it can have many potential complications ranging from infertility to the life-threatening ones like placenta acuta spectrum disorders, placenta previa, scar pregnancy, uterine dehiscence or rupture. Single or double layer closure of the uterine incision remains a topic of debate due to the fact that clinical outcomes are lacking. Our aim is to compare different layering techniques and to assess the complications in post-C-section women. Our clinical question is, does double-layer caesarean section closure technique result in a lower incidence of complication compared to single-layer closure? To answer this question, we use the PICO framework. Our population are post-C-section women with a subsequent pregnancy and those without a pregnancy. Our intervention is double-layer closure technique. The comparator is single-layer closure technique, and the outcomes are complications such as the presence of the scar defect, uterine rupture, uterine dehiscence, maternal infectious morbidity. We conducted our systematic search in 3 main databases with the following search key, which consists of 2 domains. The first one is basically the caesarean section itself, and the second one is the suturing. After our search key resulted in more than 9,000 articles, and after the full text selection and the citation chasing, we were left with 34 articles. Our first outcome is the presence of the caesarean scar defect at 6 weeks follow-up. We compared the double-layer closure with the single-layer closure, and we used odds ratio as a measure of effect. You can see that the heterogeneity is low, and the odds ratio is 0.95, which means that the scar defect was more common in the single-layer group, however, not in a clinically relevant or a statistically significant way. We also looked at the caesarean scar defect at 6 to 24 months follow-up, and we compared the same interventions. I forgot to mention previously the subgroups, which we did based on whether the surgeon used locked or unlocked sutures. Once again, we used odds ratio as an effective measure. Here the heterogeneity is high, and the odds ratio was 0.67, which means that once again the scar defect was more common in the single-layer group, however, not in a clinically relevant or a statistically significant way. The next outcome we looked at was the uterine dehiscence, which we looked at once again the double layer and the single layer group. using odds ratios and with a low heterogeneity. The odds ratio was 0.55, which means that it is more common in the single layer group, not reaching statistically significant, but being clinically relevant because we can see a tendency on the single layer side. We looked at the uterine rupture, and we can see that here we have a high heterogeneity and the odds ratio of 0.62, which means that once again the rupture was more common in the single layer group without reaching statistical significance, except for the first subgroup, which is locked in the first layer, unlocked in the second layer, compared with the single layer lock sutures. We also looked at the operative time, and as we would expect, it turned out that the single layer closure was 4 minutes faster. Our studies have strengths and limitations. Strengths like we use the highest level of evidence because we included RCTs, high patient numbers, and the methodology we used. Our limitations are high heterogeneity. As a conclusion, double layer suture decreases the risk of uterine dehiscence and rupture in subsequent pregnancies. And as an implication for practice, we would advise surgeons to use the double layer technique, providing a safer condition for subsequent pregnancies. And as an implication for research, we can say that more RCTs and cohort studies with different subgroups based on parity or previous cesarean section numbers are needed. This is my progress with the first project. Right now I am in the manuscript writing phase. And to tell you a little bit about my second project, which is comparing pregnancy rate after laparoscopic and open myomectomy. Approximately 70% of women develop one or more uterine fibroids by the time they reach the age of 50. Fibroids have been linked both to infertility and recurrent pregnancy loss, and submucosal and intramural fibroids above a certain size are the types that influence fertility the most. Compared with traditional laparotomy, laparoscopy has several advantages like reduced hospital stays, less peritoneal trauma, and this can lead to decreased adhesion formation. Our aim is to compare the safety and efficacy of laparoscopic myomectomy and traditional laparotomy and to determine their effect on the pregnancy rate after surgery. Our clinical question was, does laparoscopic myomectomy result in a higher pregnancy rate compared to open myomectomy? Our population are women with fibroids. Our intervention is laparoscopic myomectomy. The comparison is open myomectomy. And our outcome is the rate of pregnancy success after the operation. We hypothesized that the pregnancy rate after laparoscopic myomectomy has higher than after open myomectomy. And we would like to help clinicians in the personalized decision making. We use the following search key to search the databases. The first domain is basically the fibroid itself, and the second one is the method. So in summary, I would like to state my submission dates. The first one I would like to submit by June, and the second project I would like to submit by September this year. Thank you for your attention, and I would like to close with the words of Thomas Berger: the art and science of asking questions is the source of all knowledge. Thank you.
My question is actually related to your second topic, and my question would be about the population. So, wouldn't, for example, the size of the myoma influence which approach would be chosen? And wouldn't actually the size of the myoma influence the rate of the of your outcomes. So my question is how you are going to deal with such confounders in your study?
Yeah, so basically the size in this case does matter, but they can operate on quite large myomas with laparoscopy as well. So I guess that depends on the surgeon, but yeah, you can, I mean, we would expect that size would influence the results.
Thank you.
Kinche, I would like to ask about your second project that you mentioned the pregnancy rate in as outcomes. And what do you think? Where does the difference come from the open laparotomy, myomectomy, and the laparoscopic myomectomy? So where is the difference? What caused the difference which affect pregnancy rates?
Yeah. So in open myomectomy, there is more peritoneal trauma, which we would think that would lead to more adhesion formation. So maybe adhesion formation reduces the rate of pregnancy rate or successful pregnancy.
Thank you very much. Thanks.
Thank you.